the basis of my talk was to really delineate what the current challenges and perspectives in small cell lung cancer are. So to give an overview, we have made significant progress in treating these patients. In limited stage small cell lung cancer, even if the patients don't get immune therapy, just the standard previous treatment, giving the radiotherapy concurrently with chemotherapy have probably improved median survival now at about 30% 5-year survival. And part of the reason of that was just stage shift. We stage the patients better now, so we detect metastases much more frequently in our patients. So that would shift and it would make the current treatments work better because you're treating the right people. The second reason is the techniques that we use for radiotherapy, where they're much more conformal. They can actually treat the disease much better. And then we have this twice daily versus once daily treatment, which is, the sense is that it may be a little bit better than the once a day treatment. There are a number of other factors that I think are emerging as important for limited stage small cell lung cancer. One is the whole area of, should we give patients prophylactic cranial irradiation? And this is a controversial area now because the patients, because we're giving immune therapy and their lives are getting lengthened, out to 4 years, over 4 to 5 years median survival, and those patients are more likely to get cognitive impairment over time. So can we give it, or can we just observe the patients more closely? So there are trials that are going to compare prophylactic cranial radiation given up front versus those patients who go along and have observation. And those observations, when they relapse, they can then go have either prophylactic cranial radiation or SABR, much more targeted therapy for the lesions that come back. They're going to be very important in the future in defining how we look after our patients. And when we talk about patients in the clinic, people are concerned about loss of cognition. Like, it is a big problem, the brain fog. And people are concerned about this. So a lot of people do have no issue in not having the PCI. You just being in that observation arm. So I think these are going to be important trials. The other thing that's emerging as well for small cell limited stage is the dose. It looks like higher dose may actually work better than the standard doses now. There are 2 randomized controlled trials, one from China and one from Norway. There's certainly a point in that direction. And when you do subset analyses of the other trials I've mentioned, again, there seems to be a benefit for the sort of higher dose of treatment. So yeah, it's certainly an area of interest of improving things. So our challenge is to do the right trials to make sure the best treatments are given to the patients, which is, as I mentioned, chemoradiation, followed by immune therapy at the moment. Do we give PCI or not? Maybe. Do we give higher doses of radiation or not? Maybe. And how do we best incorporate radiation into the treatment with IO therapy at the same time? So chemoradiation and IO, at the moment, that's a little concerning because the patients certainly don't seem to be doing any better. So we've got to look at other strategies.